Welcome to the culture of healthcare processing, and decision making. In this episode, we'll begin exploring what it means to work in healthcare, not just the science and technology, but the culture that shapes how care is delivered every day. We'll talk about the expectations that come with working in a healthcare setting, how care is organized in practice, and why teamwork is essential. We'll also touch on important topics like privacy laws, professional ethics, and the decisions healthcare workers must make in real world situations. And throughout the podcast, we'll highlight the role of clinical engineering, the professionals who make sure the technology and medical equipment that support patient care are safe, reliable, and effective. Their work is part of the culture of healthcare too, often behind the scenes but vital to decision making and quality care. Think of this as a roadmap to understanding the healthcare environment, what guides decisions, what challenges professionals face, and how culture influences every step of that process. So let's go ahead and get started. Okay, so we're going to go ahead and describe the elements of the classic paradigm of the clinical process. We're going to list the types of information used by clinicians when they care for patients. We'll also describe the steps required to manage information during the patient clinician interaction. We'll do that through several slides or several podcasts. We're also going to describe different paradigms and elements of clinical decision making. We'll explain the differences among observations, findings, syndromes, and disease. We'll continue by describing techniques or approaches used by clinicians to reach a diagnosis. And finally, in this first part, we'll describe the role of EHRs and technology in the clinical decision making process. Now, if you're asking yourself, where are the objectives that are specific to clinical engineering? Well, in this session, we're actually going to be talking about the rest of healthcare. It's good to understand what their normal processes are before we jump in and start meddling. So, I will mention clinical engineering where we can help and where we probably should stay away from because things are working fine in healthcare. It doesn't mean that we actually have to, apply some process where none is needed or asked for. So that's why we're going to be focusing more just on healthcare itself. So hopefully you enjoy this, even if we don't stress a lot of clinical engineering and healthcare technology management in this presentation. Hello, and this session is going to be all about healthcare processes and decision making and how culture shapes both. And here's a starting point. Imagine a single patient sitting down with a single clinician. And they're going to talk about a single problem during a single episode of care. Simple, right? One patient, one clinician, one problem, one visit. But even in this straightforward setup, a whole ecosystem kicks in. Medical records, computer, diagnostics, devices, mobile devices, clinical information systems like the electronic health record, for example, the EHR. That's a layer on top of the clinical decision support system. And you've got tools helping guide care in real time. And we can't forget about communication. We got emails, patient portals, like I mentioned, through mobile devices, and other electronic tools are now essential to keeping that patient clinician interaction flowing. We'll stick with this one patient, one problem, one clinician model for most of our discussion because it's realistic in many situations and keeps the problem clearly defined. But here's the reality check. Patients often come with multiple diagnoses, multiple clinicians, and multiple visits. That's where complexity really ramps up. And that's where the culture of healthcare is moving. Along with fields like clinical engineering, right, this becomes even more critical to making sure that the systems work. All right, let's zoom in on this classic paradigm. It's not just a teaching tool, it's actually pretty close to what's been called the central theorem of health informatics. This idea comes from Chuck Friedman. And here's the takeaway: a human being working in healthcare will almost always perform better when they're supported by well designed computer tools than when they're working alone. Think about that for a second. It's a bold statement, but it's the foundation of much of modern biomedical informatics. Even if people don't say it out loud, this assumption drives how tools are designed and how care is delivered. And here's where the classic paradigm lies in. It shapes how we think about care decisions, how clinicians interact with technology, and even the design of systems like the electronic health record. In fact, that one patient, one problem, one clinician, one visit scenario is exactly the setup that many health technologies were built to support. Of course, healthcare isn't always that simple. Patients bring multiple issues, they see multiple providers, and their care stretches across multiple visits. Later in this lecture, we'll dig into those more complex configurations and how computer tools need to adapt. But for now, we're sticking with the classic model: one patient, one problem, one clinician, one visit. It's the clean foundation, the starting point, and the perfect way to understand how healthcare processes and decision making work at their core. What do we mean by clinician? You'll hear the word clinician a lot in this lecture, so let's pin down exactly what that means. A clinician isn't just someone with a medical or nursing degree. Titles don't automatically make the work clinical. For example, a nurse running a hospital as CEO or a physician designing computer systems isn't doing clinical work. Instead, a clinician is defined by the role. So they have specialized knowledge from formal education, medicine, nursing, pharmacy, and so on. They've had extensive experiential training, learning under supervision, gaining hands on practice, and earning state licensure. They have a direct relationship with the patient, providing care face to face. They make decisions about patient care, so assessing, diagnosing, managing. They carry a fiduciary responsibility as well, always acting in the patient's best interest, not their own. They also integrate diverse information: their medical training, their knowledge of the patient, and awareness of the local resources. And finally, they work under tight time and resource constraints because healthcare is rarely simple. So whether it's a neurosurgeon, a nurse, a clinical pharmacist, or a physical therapist, if they have these attributes, they're a clinician. And here's the connection: clinicians rely heavily on tools and technology to make the decisions under pressure. Excuse me. And that's where clinical engineering intersects, ensuring those tools are reliable so that clinicians can focus on what matters most to the patient. When clinicians assess and manage patients, they don't just rely on one source of truth. They pull from five key types of information, and knowing these helps us understand how decisions get made in healthcare. The first is patient data. This information about the individual, like allergies, diabetes, or a heart murmur, it comes from the patient, their family, medical records, personal health apps, or even a clinician's own observations. Increasingly, it also flows electronically from health information exchanges. Second, population statistics. Think broader trends, like a local flu outbreak or a public health report on disease frequency. It's data drawn from many patients, giving context to the person or the patient sitting in front of you. Third is medical knowledge. This is the body of science itself. Rules and conclusions pulled from textbooks, journal articles, and medical literature that apply across many patients. The fourth would be logistics information. Not what to do, but how to do it. Can the medication be obtained? Will insurance even cover it? Which surgeon is available? It's the practical behind the scenes information that makes clinical plans possible. And number five, or the fifth one, is social influence. Clinicians often look at how peers are managing similar cases. They may not copy exactly, but they want their practice to align with professional norms. You put these together, these five types of information, they shape every decision that a clinician makes. And here's the catch: they're only as strong as the systems that deliver them. That's why clinical engineering and informatics are so critical. They ensure the data, devices, and systems that feed this decision making process are accurate, reliable, and accessible. How clinicians organize information. So, clinicians don't just collect information, they constantly reorganize it to make sense of a patient's history. It usually starts as a narrative, the patient's account of what's going on. Then it's reshaped into a structured history and physical exam format. From here, it gets reorganized into hierarchies and groupings that highlight what matters most. Tools like the SOAP note, subjective, objective, assessment plan, help guide this process. And clinicians will often create ad hoc structures too, depending on the situation. Now, with today's clinical information systems, much of this information flows electronically. Lab results, radiology images, and device data go straight into the EHR. Clinicians then add their own notes, assessments, and treatment plans, creating a single electronic record that every member of the care team can access. That means one central source of truth for the patient's care and progress. And it doesn't stop there. Once aggregated, the same information powers clinical decision support tools, quality improvement projects, and research, turning individual patient data into knowledge that improves care for entire populations. And here's where clinical engineering quietly plays a role, making sure those devices, systems, and interfaces reliably capture and deliver the information that clinicians depend on. The power of narrative. Even with all the effort of structured clinical data, one thing never goes away: the narrative. There's an old saying in healthcare attributed to someone named Wilfred Trotter: disease often tells its secrets in a casual parentheses. So, in other words, no matter how many pointed questions a clinician asks, the most important clue might slip out when the patient is simply telling their story. That's why the clinical process almost always begins and often ends with a narrative. The story matters. It gives context, reveals hidden details, and ties together the structured data in ways no checklist ever could. And here's the connection: whether it's written in a note, spoken in a visit, or captured in an electronic record, narrative has to be preserved and supported by the systems that clinicians use. Clinical engineers help design and maintain those systems so the patient's voice doesn't get lost in the data. Why stories matter in healthcare. We've been talking about how narrative runs every stage of the clinical process, and here's where the work of the scholar Catherine Montgomery Hunter gives us even more depth. She shows that stories aren't just background noise, they are the main channel of communication between patient and clinician. That's why, before asking pointed questions, clinicians are taught to start broad. Tell me what's going on. That story, told in the patient's own words, becomes the foundation for everything else. From it, the clinician pulls facts for diagnosis, but also something bigger: the meaning of the illness for the patient. And that meaning shapes not just treatment, but trust. Listening carefully then isn't just about gathering data, it's about building a relationship. And often it's therapeutic in its own right. Many patients will tell you being heard is part of healing. So, even as we move deeper into structured formats, EHRs, and decision support tools, the patient's story has to stay at the center. And here's the link: clinical engineers play a role too, making sure the technology doesn't silence the narrative but instead supports it, make sure that it's preserved and connected to the bigger system of care. Storytelling among clinicians. So, stories aren't just how patients communicate with clinicians, they're also how clinicians communicate with each other. A structured narrative is often the fastest, clearest way to share what's going on with a patient. But storytelling in healthcare goes deeper. It's part of the hidden curriculum, the informal way values, ethics, and professional norms are passed along in practice. In other words, stories teach more than facts, they teach culture. Here's the challenge: our modern healthcare system doesn't always leave room for stories. Time pressure, complex multidisciplinary teams, that's intra and interdisciplinary. The fragmented care often squeezes them out. Clinicians may shorten or alter the story, skip over opportunities to hear it, or strip out the context in a way that loses meaning. And when that happens, something vital gets lost. Not just clinical details, but also the human connection that guides ethical and compassionate care. That's why it matters that both clinicians and clinical engineers think carefully about how technology is designed and used. Systems should make storytelling easier, not harder. The patient's voice and the clinician's story about that patient still need to flow through it. Interpreting the story. Gathering data is only the first step. The real challenge comes in how clinicians interpret that data, and here's where the stories take on new layers. Different professions see different things. A neurologist and a psychiatrist might look at the same patient but focus on very different details, drawing different meanings from the same story. That's a reminder that interpretation isn't fixed. It's shaped by training and perspective. Now put clinicians together, especially in interdisciplinary care, and something else happens: social construction. In places like the ICU, rounds often sound like a conversation, but what's really happening is meaning being built in real time. Through dialogue, debate, and consensus, the team creates a shared story of the patient. And maybe the most important factor: context. A single piece of information, say a fever, means something very different depending on the patient's history, depending on the setting, the clinician's lens. Context gives data its true significance, and here's where clinical engineering fits in. The systems we build and maintain need to respect this complexity. Devices, records, and tools can't strip away the context. They should support clinicians as they shape raw data into a meaningful story that guides care. From the clinic to the operating room. So far, we've been looking at the classic paradigm: one patient, one problem, one clinician, one visit. But let's compare that to a very different setting: the operating room. Here, the patient and problem are still singular, but the team isn't. Surgery usually means many clinicians from many disciplines, all working together at the same time. It's a fast paced, highly collaborative story that's unfolding in real time. The operating room looks different in other ways. It has a short time horizon, one focused on procedure rather than long term management. The clinical focus is very narrow, but the planning is detailed, and the resources are rich. All of the changes that are involved with things like health information technology, well, that actually helps. Tools need to support team based synchronous collaboration, not just a one to one interaction. And here's the storytelling thread. So in the OR, the narrative isn't told by one voice, it's co authored by a team. And just as with the ICU, clinical engineering plays a quiet but critical role, making sure the technology allows that shared story to be heard clearly without losing detail or context in the process. Complex acute illness, right? So let's look at a different story. Let's step out of the operating room and into another very different setting: complex acute illness. Here, the classic one patient, one problem, one clinician, one visit model no longer applies. Instead, you've got one patient with many problems: lung disease, kidney disease, diabetes, and infection, and many clinicians each bring in their own perspective. The time horizon is short, and the story is often unpredictable. New problems appear suddenly. Data can be incomplete, unclear, or just plain uncertain. And because of that, the care plan can't be static. It has to be flexible and dynamic, with constant replanning as the story unfolds. It might sound familiar to a TV show that you're all familiar with. This changes what's needed from technology. Clinical information systems in these scenarios must support rapid updates, flexible workflows, and real time collaboration. It's very different from the simpler one to one setups. And here is the thread. When the story of illness is this complicated, technology and clinical engineering have to rise to the challenge. They help clinicians keep pace with shifting data, multiple voices, and the uncertainty that defines critical care. The emergency department story. Another place where the classic paradigm breaks down is the emergency department. Here, it's not one patient with one problem, it's many patients with many problems all at once. And there are many clinicians trying to manage it all, usually in a single visit. Some cases are brand new, others connect back to earlier care, but the pressure is the same. Time is extremely short. You've probably heard the phrase treat 'em and street 'em. It captures the constant need to keep patients moving through the system. In this environment, clinicians must be ready for anything: acute crisis, routine complaints, resource shortages, and the unexpected. Success depends on fast, effective coordination, cooperation, and collaboration among the whole team. And the story doesn't always end in the emergency department. Patients may be admitted straight to inpatient or critical care, so the story has to be handed off without losing vital details. All of this shapes the kind of information technology needed in the emergency setting: tools that are fast, flexible, and able to keep pace with the chaos. And once again, clinical engineering is a part of that invisible backbone, making sure those systems don't fail when the stakes are highest. Returning to the classic paradigm, after exploring the operating room, complex acute illness, and the emergency department, let's return to the classic paradigm. That one patient, one problem, one clinician, one visit model. At its heart, patients usually come to a clinician looking for answers to three simple but profound questions. What's the matter? So, in other words, what's the diagnosis? What can be done about it? The treatment plan. And what will happen to me? The prognosis. Those questions map directly onto the classic steps of clinical care. And the rest of this unit dives into how clinicians work through them. So, first, gathering data from the patient, analyzing findings to make sense of the story, reaching a diagnosis, balancing context to recommend treatment, and communicating results to the patient, the care team, and others who need to know. It's the patient's story transformed into clinical reasoning and then translated back into communication. And as always, the role of technology and clinical engineering is to support this flow, making sure information is accurate, connected, and usable for every step of the way. Let's wrap it up. That brings us to the end of this lecture, Healthcare Processes and Decision Making. Let's recap the story we've traced together. So, we've explored the central theorem of health informatics that clinicians perform better when supported by well designed computer tools and medical devices. We defined what it truly means to be a clinician, not just by degree, but by knowledge, training, direct care, and responsibility to the patient. We looked at the types of information clinicians use, from patient data to population statistics, medical knowledge, logistics, and even social influence. We outlined the classic paradigm: one patient, one problem, one clinician, one visit, and then contrasted it with other things like the operating room, complex acute illnesses, and the emergency department. And finally, we tied it back to the questions the patients really want answered. What's the matter? What can be done? What will happen to me? Through it all, one theme has carried us: the power of storytelling in healthcare. From the patient's own narrative to the clinician's interpretation to the shared story built across teams, stories shape decisions and outcomes. And woven into that fabric is the work of the clinical engineer, quietly making sure that the tools, systems, and technologies clinicians rely on keep that story intact, keep it accurate and alive. So thanks for joining me on this first lecture here. Up next, we'll continue unfolding the story of healthcare. We're going to look deeper into how decisions are made and how technology shapes those processes.